Bismillahirrahmanirrahim. So the next topic is IgA nephropathy. IgA nephropathy is identified to be one of the most common causes of glomerulonephritis. It is typically characterized by the presence of defected IgA antibodies in the blood, which are deposited on the kidneys and cause IgA nephropathy. HSP, which is also known as Henoch-Schönlein purpura, and IgA nephropathy are actually the manifestations of the same disease, with the HSP involving kidneys, skin, and GIT as well. So IgA nephropathy can be either primary, which means it is of idiopathic nature and the cause lies within the kidneys, or it could be secondary, which occurs most commonly due to liver diseases. So coming on towards the pathogenesis. So in this case, there is a defective synthesis of IgA antibodies. The defect basically lies in the O-linked glycan chain of the IgA antibodies, which identify as the antigens. So IgG or IgM antibodies are formed against these antigens, and there is also a complement system activation by an alternative pathway. So the immune complexes are deposited in the mesangium, which release the cytokines. The cytokines recruit the inflammatory cells and also the growth factors, which increase the proliferation of mesangium. So these inflammatory cells could be either macrophages, monocytes, or neutrophils, which cause the inflammation and damage the glomeruli. The defective IgA antibodies are known as IgA1 antibodies. So coming on towards the morphology. So the glomeruli in IgA nephropathy have a variable appearance. They could be either normal, or there could be a widened mesangium with endothelial proliferation. The mesangial widening is occurring due to two reasons. The first is that there is proliferation of mesangial cells, and the second is increased matrix deposition. In some cases, only segmental proliferation is present in some glomeruli. Leukocytes are also present, which include macrophages, monocytes, and neutrophils. The healing process goes on hand in hand with the IgA nephropathy in some glomeruli. Therefore, secondary focal segmental sclerosis is also present in few glomeruli. So you can see here, there are inflammatory cells present, and the widening of mesangium is also evident. The electron microscopy reveals dense immune complex deposits in the mesangium, and sparse deposits are also present sometimes in the capillary walls. Immunofluorescence microscopy reveals C3 and IgG immune complex deposits in the mesangium. The C3 deposits are more common than the IgG immune complex deposits. So the disease presents in children or young adults. It is characterized by the presence of hematuria, which lasts for days before the remission and returns after a few months, and the cycle goes on with the hematuria. Proteinuria could be either present or absent. In some cases, proteinuria could be so much that it can reach up to nephrotic range. Renal function tests are mostly normal in the start of the disease, and 15 to 40% of cases of IgA nephropathy progress to chronic renal failure within 20 years of diagnosis. So such patient will require dialysis and renal transplant. Recurrence is common in the transplant cases as well, with the slow progression of the disease identified by the deposition of IgA antibodies within the mesangium. The definite diagnosis is established by the detection of IgA antibodies in the glomeruli. If you have any questions, do let us know in the comment section. Thank you.